Welcome, everyone. Deputy Director General, honourable ministers, distinguished guests, and colleagues from around the world who are joining us here in person here at Geneva at the sides of the World Health Assembly and those who are joining us online. It really is an honour to welcome you to this really important and timely event on setting priorities, optimising resources in Africa, the new public health order, hosted by Africa CDC and co-hosted by the Centre for Global Development, the UK's Foreign, Commonwealth and Development Office, and France's Development Agency. My name is Pete Baker. I am the Deputy Director of the Health Programme at the Centre for Global Development, and I'm also I have the honour and privilege of being the Deputy Director for a network of partners that works with countries on this very topic here today, known as the International Decision Support Initiative, iDSI. I think this event comes at a really opportune and timely moment. Following the COVID pandemic, many countries are facing extremely difficult economic situations that is causing pressure on their health budgets. Countries are making more and more difficult choices on what health services to provide to their populations, and sadly, which cannot, given budgets available. It really is a life and death decision for the patients that go to those health services. 10 years ago, recognizing this challenge, all countries around the world do face this challenge, came together at the World Health Assembly to pass a historic resolution calling for all countries to set up what's called evidence-informed priority setting processes in the heart of government to look at the evidence, explicitly discuss the pros and cons of different health services to be provided, and make those difficult challenges. Since its establishment, Africa CDC's Health Economics and Financing Programme has been leading the way on the continent in driving this agenda forward. It's been a great privilege from my perspective to have watched that develop and expand its role and lead the agenda on the continent. And so this really brings us here today. This event brings together policymakers, topic experts, and leaders around the world to discuss and debate progress since 10 years ago on that World Health Assembly resolution in the African continent. And it will highlight countries with success, countries that have learned a lot, and how Africa CDC is now leading a new initiative to drive a new Africa-led agenda for better priority setting in health, and provide some inspiration for how we can all support this agenda. So, firstly, I'd like to please welcome our eminent keynote speaker, Dr. Raji Tajuddin, Deputy Director of Africa CDC, to join us here on the panel for a keynote address. Many thanks.
Good afternoon. Let me also try my French a bit. Bonsoir. So, and allow me to first and foremost apologize for coming late. We just left the Palais. There's ongoing discussion there, and I'm surprised that Salam got here before me. Yeah, so having said that, I bring you greetings from Dr. Jean Kasea, who was actually scheduled to be here this particular time. But due to the fact that that other event got delayed, the following one also got delayed, so he asked me to come and deliver his remark on his behalf. So whatever I say is a statement from Dr. Jean Kasea, because I'm actually not scheduled to be here. So, Your Excellencies, distinguished colleagues, ladies and gentlemen, allow me to welcome you all to these important side events taking place on the margin of the 77th World Health Assembly, which is setting priorities and optimizing resources in Africa, the new public health order. I'm sure we all know the new public health order by now. This is an initiative that has been endorsed by our head of state and government, and is underpinned by 5 critical pillars. Number 1 is to strengthen public health institutions on the continent of Africa. Number 2 is to expand workforce development on the continent of Africa. Number 3 is to build local manufacturing capacity for air security commodities, talking of vaccines, therapeutic diagnostics, and other medical products. Number 4 is domestic resource mobilization, which is part of what we are discussing here today. Number 5, which is much more critical to the discussion this afternoon, is around partnership, respected, action-oriented partnership. So these are the 5 key pillars under the new public health order as articulated by our head of state and government. Your Excellencies, colleagues, ladies and gentlemen, Africa stands at a crucial moment in its history. We are aspiring to build a continent that is integrated, that is prosperous, and that is at peace with itself come year 2063. That is the socio-economic blueprint for the continent of Africa, as articulated and endorsed by our head of state and government. A healthy population is a cornerstone for any flourishing economy and social development. Healthcare, you will agree with me, plays a crucial role in protecting and maintaining the health of people alongside other social determinants of health. And this readily reminds us that health is not just the agenda of Ministry of Health alone. It's a whole of society agenda. And that underscores the need for the whole of society approach whenever it comes to discussing health and health-related issues. We are aware of the challenges of the health systems as far as the continent of Africa is concerned, especially when it comes to the aspect of meeting the needs of our people. And this becomes much more critical when it comes to emergencies. We also saw the way the COVID-19 pandemic disrupted the routine health services. We saw the way the COVID-19 pandemic decimated our primary health care system. So going forward, we need to put all hands on deck to make sure that we have a resilient health system in place so that when the next pandemic comes, which is a matter of when, not if at all it will happen, so that those routine health services, immunization, management of non-communicable diseases, access to those chronic medications, childhood illnesses, we continue to run hand in hand as we respond to our emergencies. Your Excellencies, the continent of Africa is responsible for 16% of the global population. However, we bear 25% of the global burden of diseases. And sadly, we are responsible for only 1% of total expenditure as far as health is concerned. So you can see the statistics, really, I don't want to say it doesn't make sense, but it shouldn't continue like this. I think that is why we are here, and that's why we need to come up with how do we better prioritize our resources as far as healthcare spending is concerned. This situation is further compounded by the fact that the continent records on the average more than 150 outbreaks per annum. Last year alone, the continent of Africa recorded 164 emergency events, which further, weakened the already weak health system in our member states. The current unfavorable economic landscape, both globally and within the continent of Africa, warrant effective ways of tackling these challenges in the face of limited fiscal space to ensure our ambitions and long-term visions are materialized. Our approach is to seek innovative ways of raising additional resources for public health. We cannot continue to do the same thing the same way and expect different results. So this is really time for us to really look at what else can we do in an innovative way to make sure that we get resources adequately channeled towards health. Equally important, but yet let's discuss solutions to the challenge is finding ways to ensure maximum value is obtained from the available resources. How do we better optimize what is available? I think that is a discussion we should have this evening, and I urge all of us to bring the whole of ourselves into this room, and have a very robust discussion on how do we better optimize the resources available to us as far as the healthcare spaces are concerned. Evidence-informed priority setting lends a powerful tool, enabling navigation through the complex resource allocation decisions among competing priorities granted on evidence conducted in a transparent and inclusive manner. In the absence of evidence-informed priority setting, implicit and additional decision-making practices risk inconsistent, and suboptimal outcomes with life and death implications for millions, especially on the continent of Africa. Recognizing the huge potential evidence-informed priority setting as in tackling this conundrum, the 67 World Assembly unanimously passed the historic resolution 67.23, which I believe we are all aware of. This resolution underscored the global consensus on the importance of a structured framework for health decision-making processes, advocating for the implementation of evidence-informed priority setting as a fundamental principle in the management of healthcare resources. I think this will also allow us to better engage our political office holders, our decision makers, our ministers of planning, our ministers of finance, so that they can channel appropriate resources to health. Since this resolution was passed, evidence-informed priority setting gained traction in the health policy arena. Different partners have led initiatives to support AU member states incorporating evidence-informed priority setting into decision-making. These efforts, however, were not always in the best interest of our member states. So again, we want member state-owned, and member state-led process. So as much as possible, let's ensure that whatever approach, it should be in the best interest of our member state. In the case of emergency preparedness and response, we've seen a growing need for ensuring efficiency and value for money in the use of limited available resources. However, efforts have been limited to costing, with little to no guidance on how countries can systematically optimize the available resources. Recently, Africa CDC, just 7 years old, we've worked with country ministries of health, the key partners in this space, including our colleagues from WHO, our colleagues from the French Development Agency, our colleagues, as you can see on the screen there, all those partners outlined on the screen there. We've developed and launched a continental framework for evidence-informed priority setting in Africa, along with guidance on how member states should institutionalize and incorporate this tool in the way they allocate resources towards health. And this actually followed extensive consultation with our member state because of what uses a tool that member states are not going to use or member states are not going to have confidence, in deploying. So it's a member state-led process, as I said, and as we operationalize that tool, we will continue to work with our member state. So it's my hope that during the panel and the subsequent moderated discussion, all of you will actively engage to share your experiences, bring on board best practices from other settings, and how do we better deploy this particular tool. The Africa CDC Director General is committed, to really working with the key stakeholders in the space, to make sure that it's not just one of those action plans that we see it on the shelf, but for him is to action this action plan. So, colleagues, ladies and gentlemen, that brings me to the end of the remark from the DG. I thank you for your attention, and I wish all of us a successful deliberation. Thank you.
Thank you very much. Could I now invite a second opening remarks from Dr. Salim Gay from WHO Afro, the Regional Emergencies Director. Thank you.
Good afternoon, everyone. It is an honor for me to stand here and make a remark on behalf of Dr. Matshidiso Moeti, Regional Director for WHO Afro. And as my friend, Dr. Taz said, there is important discussions that are happening now at the World Health Assembly related to the Intergovernmental Negotiating Body, which is, in a way, how we can optimize the resources to save life in the whole world. And here also, it is an important aspect that we should take into account. And I am pleased to join you to highlight the importance of making effective choice in health. And I commend our collaboration with the Africa CDC on the health economics financing program, which raised policy awareness and this critical issue. The idea of prioritization is not new, but also it is determined and become more a priority based on the context. The aftermath of COVID-19, there is a scarcity of resources, and also the needs are big. That's why the focus on prioritization, as far as we are concerned, we believe that the primary health care is an important part that we should take into consideration. In the Africa region, the financial level from domestic public resources for health remain inadequate compared to the resource requirement. Just to share with you here some numbers. In 2021, in the middle of COVID-19, the health spending in the region was on average $132 per person, with the government share, which is only $65 per person, which is far from the objective of sustainable development, which are $249 per person. At the same time, the fiscal constraint, you know it, in almost all the African countries is a problem. So optimizing the resources is necessary. And in particular, the external funding comprise on average 20% of the current health spending between 2021 and 2022. And in some countries, it reached 40%. And that part, I'm just taking a little bit out of my speech, need also to be checked, because most of the funding that are external to government and to the population, sometimes the investment is not as optimized as it should be, because the decision, Africa is not sometimes involved. All this emphasizes the need for priority setting in countries, and it must be done with the appropriate evidence base. However, countries still need the tools to translate the evidence to make effective decisions on prioritizing adequately. WHO Afro has championed this cause for a decade now. And we work with countries, particularly to develop essential health package during the strategic planning, during operational planning, and also when we accompany them during the implementation. We have also demonstrated this collaboration with Africa CDC in raising awareness and building the capacity of policymakers in Eastern and Western Africa in priority setting in health. We remain committed to sustaining this collaboration and partnership and providing technical guidance to countries in the Africa region for improved health outcome and well-being. I will finish only by making a challenge. Isn't it possible that primary health care be accessible financially without any help in Africa? Things like telephone, you go to Africa now, over 80% of the population, including those that are considered very poor, have access to telephone, and there is no subsidy, because there is a financial model that were capable to prioritize that and to make it accessible to the population, and the population are ready to pay for what they are getting from. And I'm sure that if we are able to prioritize also primary health care, which in my opinion may not be more expensive than telephony, we will be able to have a population that can pay for themselves. Thank you very much.
Thank you very much, and thank you for the reminder that that donors and partners also have a key role to play in this project, which is timely because now we can welcome Ella Carpenter, the Deputy Head of Global Health Institutions at the UK's Foreign, Commonwealth and Development Office. Thanks, Ella.
Thank you very much, and I'm really delighted to be here this evening to discuss with you all the important topic of priority setting in health. The UK is really pleased to be co-hosting this event with Africa CDC, the Centre for Global Development, and France's Development Agency. And it's fantastic to have such a great audience here. I know we've got lots of really esteemed colleagues, and I understand lots of people online, so looking forward to the discussion after opening remarks. The Africa Union has shown long leadership on mobilising resources for health, from the seminal 2001 Abuja commitment to the Africa Leaders Meeting initiative today. But we are in an era of multiple overlapping crises. Public spending is contracting in many countries following the pandemic, while demand on public services is increasing. Many members of the Africa Union face challenging health demands, exacerbating by the health impacts from climate change and antimicrobial resistance amid constrained public finances. Rigorous priority setting is part of meeting this growing challenge. It provides the evidence needed to make bold decisions to invest in health promotion, prevention, and quality primary healthcare. A small investment in priority setting can generate large benefits. We see in the UK benefits of our National Institute for Health and Care Excellence, NICE, one of our health technology assessment programs, costing £367 million, identified interventions with a net benefit of at least £3 billion. We do not have limitless health budgets, and all countries must make their own choices on the path to universal health coverage. Priority setting can also help us make fair choices that focus not just on cost effectiveness, but on who benefits and who might be left behind. It helps bring what households and communities want and value into decisions. When it comes to partnerships to support this, we believe that priorities should be set by national actors. The role of partners is to align our investments and support behind these agreed priorities and, where possible, joint plans. That's why we're pleased to be supporting the Joint External Action Plan, which is spearheading regional collaboration across Africa CDC, WHO Afro, and WHO EMRO to strengthen health security. It's also why we are championing the Lusaka agenda on the evolution of the global health initiatives. We want to embed country leadership and ownership, harmonise support from external partners, and facilitate investment to sustainable health systems. Partners can help to catalyse action on transformative agendas like priority setting. The UK is proud to have supported platforms like the International Decision Support Initiative that have spearheaded this. Leadership of this agenda is now firmly in the hands of the African Union. Africa CDC, with WHO and partners like the Kenya Medical Research Institute, are at the forefront. Our role as external partners is twofold: to back your leadership and complement it through catalytic funding and collaborations with the best of UK expertise from our universities and public institutions like NICE. That's why we're pleased to co-host this event this evening and look forward to strengthening our partnership with Africa CDC. They've built a fantastic platform, demonstrated by their launch at the Africa Union's priority setting framework. And we will continue to offer UK expertise where this is sought, such as the ongoing collaboration between our priority setting institution, NICE, and its counterparts in South Africa. These collaborations embody the principles of our recent white paper: mutually respectful partnerships, led and owned by our partners, such as Africa CDC, with long-term sustainable vision of progress. We look forward to continuing this journey together, working hand in hand to grow and sustain investment in health and move the dial on universal health coverage and health security in Africa. Thank you, and really looking forward to the discussion.
Thank you very much. Now we'll turn to a panel discussion. So could I invite all the panelists up onto the stage, please? And whilst they're getting ready, can I introduce Dr. Javier Guzman, who is the Director of Global Health Policy Programme at the Centre for Global Development, who's going to be facilitating the conversation.
Thank you very much, Pete, and welcome everyone. Thank you very much for being here. It is a pleasure to have you all, and it is a pleasure to have 4 esteemed panelists who are going to tell us a bit more about evidence-informed priority setting, what we've learned from the past, where are we exactly, and how we will see the future. So let me introduce the panelists first. So on my left, I've got Dr. Tessa Ediger. She's from the Philippines. And she's the acting director of the Department of Health, Financing and Economics at WHO. Thank you very much, Tessa, for being here. We've got Justice Novignon. He's the head of the Africa CDC Health Economics and Financing Program. You've heard about that program before. We also have Mirav Tadesse Tola, who is the principal health economist at the same program, the Health Economics and Financing Program at the Africa CDC. And we have Pete Baker, who you know, who is the Deputy Director of the Global Health Program at the Center for Global Development. So let's get started with some questions. Also, please do have your questions ready, because we'll have a very vibrant session of questions and answers with you all. But to get started, I guess, Tessa, we've heard about where we are in terms of a difficult economic climate. We've heard about the potential benefits of evidence-informed priority setting, and you've been in this universe, in this space for decades, interacting with the Ministries of Finance, the Ministries of Health. How do you engage with the Ministries of Finance and Ministries of Health to make them see that this is important? Thanks for being here.
Okay. Before I answer that question, I think it has been hinted that I have been forever in this game. And I'd like to acknowledge that actually it is an institutional commitment. And while I kept this seat warm together with Joe Kutsin, I'd actually like to acknowledge Anya Suka, who's here, who was actually the health financing, I think we called it governance department director. And by September 15, we will have Calypso Chokidu joining us, and she will take over the seat that I have been warming. So it is, you can see them here, and I think this is what we're saying. This is an institutional commitment. This is WHO. We've worked in this area. I think it's easy that it's, when we talk about prioritizing health interventions, we have a common metric, healthy life years, or even life saved sometimes, if you want to focus on life-saving interventions. It's relatively easy. We have a way of dealing with this in terms of priority setting. It has been around, as our UK colleague said. NICE has been around for so many years. They've led the development of this, and now I think we are enriching it with what we're doing in Asia, in Africa, and all the other countries. It's relatively established now, health technology assessment. The processes, we have been able to prove that it is very cost-effective as a process in itself, that it is a fair way of making decisions, and that it is we recommend high transparency in doing this. So there is no more contest about this. The best decisions are made on health interventions using health technology assessment, applied as a process and directly translated into a decision, whether reimbursement or publicly financed by the central government. And I think we shouldn't lose fact that it should actually be implemented as a package. What I want to say is, I think we also have growing consensus on what would be a core set of primary health care services. And actually, the question we should ask ourselves is not what should we be providing, but it should be what should we be providing next. It is our duty already as a human right to provide a core set of services universally. And so I'll stop here. And I think I would like to actually say that's primarily been a ministry. I just want to make one other point. That conversation takes place within the Ministry of Health. Once you want to go up to the Ministry of Finance, we have to make our case to increase domestic investments in health. And that's a different conversation. And it talks about other criteria that needs to be taken into consideration. What we do want to, what I want to echo here, however, is what our Council on Economics of Health for All has said. The economy is there to serve and promote health and development. The economy is not there, or the Ministry of Finance is not there to just look at GDP growth. That is important, but it is a means. And that means is the means to health and well-being. So I think we can make our case. We just need to prepare for it. I'll stop there. Thank you.
Thank you, Tessa. Justice, if I can turn to you, you know, we heard how we now have the Health Economics and Financing Program at the Africa CDC, and you've spearheaded that effort. How do you see the future in terms of opportunities, challenges, in this area of evidence-informed priority setting?
Thank you, Javier. A lot has changed. A lot has changed. If I look back, at least at my short life, 15 years ago, only 15 years ago, as a PhD student, when my mentor introduced me to consulting, economic evaluations, for a couple of years, I realized that actually governments were not coming to request that we evaluate programs. They were mainly development partners. So donors were coming and asking, can you evaluate this program that a government is running? And of course, we were getting our money, but I was worried that this was not coming from government. Today, in fact, this year alone, the Health Economics and Financing Program has received requests from 3 of the 5 biggest in terms of population size countries on the continent. And these requests have come from Office of the President or the Minister himself sending out some requests and saying, listen, can you evaluate this particular intervention for us? This is not someone writing, but coming from that high level. And for me, I think that shows that the policy visibility for, evidence-informed priority setting has changed, and it is changing. So that's one big change that has happened. And of course, I mentioned 3, but those are 3 that have said, can you come evaluate? The numbers that have said, listen, we need capacity developed in this area, we cannot count them. So this is changing. What is the future? The future is very bright. I mean, I think that Africa CDC is in a very good position to help solve one of the challenges that we've seen in priority setting on the continent. And that is how the TA, or technical assistance, was delivered. This is coupled with, capacity. We do say there is lack of capacity. Usually there is some capacity, but the way the capacity is harmonized, and delivered to support the countries may not have been the best. Now working with partners, with WHO, with iDSI, with KEMRI, and with all the others, we've seen, some push or move when countries, whether it's the policy community or is the emergency preparedness community, we see one voice speak that we need one harmonized way of, incorporating evidence-informed priority setting in what we do. So the future is very bright, but it requires that we intentionally strengthen country capacity to drive, country-led agenda around priority setting. So those are the two things that I would say.
Thank you, Justice, for highlighting, the bright future and, country-led, country-owned, and how the Africa CDC is leading the way. So building from that, I wanted to ask you, Miraf, about something that we've heard.
Yeah.
We heard about the priority setting framework.
Yeah.
Can you explain a bit what that is and why it is important?
Yeah, so the continental framework for priority setting is kind of guidance that we recently developed, co-created with extensive involvement of the member states and partners, basically to guide them on how they can effectively incorporate, evidence into their decision-making processes and institutionalize it, not to make it just a one-off process. And the motivation for that is, as has been mentioned by the prior speakers, a lot is already being done and has been done in the space. But in our engagement and consultation with member states, what we understood is the support countries were receiving was not necessarily responding to the unique needs and challenges they are facing. And also the support was not necessarily in a well-coordinated manner. There was a lot of duplication of efforts and lack of considerations for sustainability moving forward, right? So that is one of the motivations for coming up with this framework. And the second is being an Africa CDC. We're also very concerned about emergency preparedness and response. And as health economics and financing unit within the Africa CDC, we also sought to find ways of incorporating, bringing economic efficiency and that concern into the decision-making space in the resource, in the emergency preparedness and response space. And a lot of guidance is available, but they don't adequately, or to a large extent, they do not actually provide guidance in how countries can think of optimizing resources, even in the emergency and preparedness context. So the motivation behind developing this continental framework is to address this pretty much two main concerns. So in response, what we did is we actually established a governance structure to lead the process, the development process, and the governance structures were composed of people from member states, largely the different member states, from different sectors, Ministry of Health, academia, HT experts, but also we've included international experts, and we did this through extensive consultation with member states to understand their unique needs, because that's the one thing we wanted to respond to. And we had overall, we engaged with more than 40 member states, which basically means about 75% of the 55 member states were responsible for, in the form of country visits to learn what is going on. There's already some progress in some of the countries, a lesson that can be taken for the others. And then we interviewed experts, but also did extensive consultation with them, even from the start, to say, how do you want this to be, like, in how, to find out the ways we can be more supportive to them. So to identify the needs. We did that in the beginning, where we brought about 23 member states from the different parts of the continent, and then continued working further, developing the framework, and midway we checked in with them to see if this responds to what is in their expectation. And then in the end, just recently, about 2 weeks, I think 3 weeks, end of April, we brought together about 40 member states from across the continent to basically validate and solicit further input to make it responsive to their needs. So country ownership and country-led process to homegrown response to home challenge in the home, right? Yeah.
Thank you,
in terms
Miraf.
of,
I guess important to highlight one, well, the beauty of the Africa CDC as part of, the African Union, how you can convene member states. And two, something that is interesting because we learned about priority setting and HTA in the context of universal health coverage, but now you're saying it is important to apply methods for pandemic preparedness going forward. So with that, I just wanted to turn to Pete. I mean, Pete Baker has been working on priority setting for a very long time as part of the International Decision Support Initiative. But I just wanted to first acknowledge Calypso, who was a founding member of the iDSI network. Now, of course, she's going to WHO, but she was the one who initiated a lot of this work. So thanks, Calypso. After 10 years of work with the iDSI network, what are the lessons learned in terms of, priority setting, technical assistance, and working with countries?
Yeah, thanks, Javier. So, as part of the network, we've had the privilege of working with and following countries as they build these institutions over many years. And I guess the lessons that are coming out of that experience are quite wide-ranging, and some of them are unique, but there are also some common themes that we can pull out. And you'll actually see on your chairs there's a flyer where you can dig into all the details that you might want on the lessons that came from those countries. But just to flag a few interesting ones, I think the first one is, I guess what Tessa mentioned. It works. Like, it is possible for countries to build core government institutions, core government capacity that can look through the evidence, explicitly deliberate over its quality, make tough decisions, and allocate resources to deliver the optimal or best services for their populations that can be afforded. We've got many examples of this across Africa. Probably Ghana, where Justice led much of the work, is a nice example. But probably the example that's evaluated the best is in India. And we found that for every dollar that the Indian government spends on this kind of mechanism, you get about $9 of additional health system performance. So it really produces a large amount of value. But that value depends on those kind of decisions actually being implemented. So probably the second key lesson we learned is implementation matters, and it has to be planned from the beginning. So India found that partial implementation, like they've currently got, leads to about 9-to-1 that I just mentioned, but it could be as high as 71-to-1. So if you could really maximize implementation, then that's what can really produce impact. This is not easy, this area. It's probably the third lesson. It's intensely political is the main problem. So you're talking about how you allocate not only large amounts of resources in your public sector, which produces interest groups, but you're also talking about how you're going to save lives and which lives you can't save. So of course, there's going to be a lot of passion and intensity in these debates. The second part of that is that this political nature of it is over the long term. It takes years to build, and so you have to have sustained political will, not just for 1 year, not just for one minister, but sometimes over the long term, which requires quite complex building of coalitions for it. I guess the final thing to say is, or final lesson that I want to sort of pull up on is this kind of donor-government relationship on priority setting. Like, global health initiatives have a very key role to play, donors have a very key role to play, and historically they've not always played that in the most supportive way. There's been a history of developing parallel priority setting mechanisms that might not help build, but may actually even undermine the kind of coordinated national priority setting process. And so something like this continental framework that can stimulate people to come together and align behind one single national plan, one single priority setting process is really key. Thanks.
Thank you, Pete. Tessa, can I go back to you? We've been talking about Africa and the importance of the regional approaches. You've been working in other regions. What can you say is important to keep in mind now that this is basically developing in the African continent? What can they learn from other regions and experience there?
I think there are many lessons to be learned, but I think one that really needs to be taken into consideration is, what are the efficiencies that we can attain if we do it in a certain way versus another way? I mean, talking about institutionalizing HTA, but taking the same process of saying, we should establish this in the most efficient way because we have limited resources. Investing in institutionalizing HTA needs also investing in human resources, investing in a certain structure to make it effective. I think the first, we sort of keep our eyes on what's happening in the HTA world. And it's interesting what happened in Europe. In many of these countries, they already have their own HTA agencies. And really, you know, they started on this a long time ago, and they invested, and they built up institutions. And then suddenly you hear, or not suddenly, you know it's been over a process of, I think, 20 years of support on what they were calling a regional approach to health technology assessment. And then in the end, they decided to pass a, what do we call it in their terms, the European Parliament, like a resolution where they said it was binding, that clinical effectiveness studies could be done, and it could be binding on all. So that's one part of health technology assessment. It is the assessment of effectiveness. And if you think about it, we all do the same thing. We do systematic reviews of interventions. And the question is, how many times can you do a systematic review? Over and over again. So it actually becomes what you could already label as a public good, a systematic review of an intervention. And that's the actual question of whether that could be an approach which could be adopted by many of the regions, and then maybe a little bit more. So for example, for Africa, you might say, okay, there's a systematic review on clinical effectiveness. It might be possible for, if it was a hypertension drug, because maybe the mechanism of hypertension is different in Africa, that maybe it might work differently. So you would still do a regional assessment of something which is a global systematic review. So there is still a role for regional approaches to assessment of clinical effectiveness. And we said that if there is a setup for this, and we thought that maybe looking at what is happening in the European Union, if there is already a common market, and particularly if there is already an approach which is regulatory, which is also regional, like I think you are planning an African FDA at a certain point, once it is endorsed by the member states in their parliaments. And then you actually have a very good setup for a regional HTA approach. And I think this is something that can be explored in ASEAN, in the regional market in Asia. They are approaching this now. They are now looking at their methodologies and trying to see where the commonalities are, where the differences are. So I think this is an approach you sort of think, does every country need in Africa, the 55 countries,
Correct.
need to do their own systematic review? Probably not. But economic evaluations are important. And maybe that's also where there should be real capacity in every country. But there are still efficiencies to be gained with economic evaluations. You can talk about models that could be generic at the start and then can be contextualized. So I think there are many approaches to this, but a regional approach with the foundation of your institutional framework, which you already have, I think is a very good way forward in further utilizing regional capacity to benefit the region as a whole, and not to wait for every country every one of your 55 member states to actually build up an institution on its own. And with all of the IT coming in and all of our easy communications with each other, I think that is really the way forward.
Thank you very much for that, Tessa. Justice, do you want to comment on what the future will be, the leapfrogging, the methodologies, the regional versus national? How do you see it from where you sit?
Thank you. For us, it's not so much of a regional versus national. So the question is not this versus that. The question is, how do you combine both? We have, many of the countries that already have the resources, at least some resources, and they have the motivation to develop their own structures. Ghana has done something. We know Kenya, Ethiopia. Recently, we had a conversation about Malawi that, they are internally motivated to do that. So let them do that, help them to develop those capacities. But of course, there are countries like Comoros, the small countries that may not have the capacity to do that. Develop a regional approach for them. So for us at Africa CDC, this framework is not a paper that we are going to keep talking about. We already have, plans of how to develop, how to roll out this at different levels. I mean, there are regional level activities that will happen to benefit all countries within the region. And then there are selected country activities, that would happen to develop the methods. For instance, we're already having discussions, and I won't say don't quote me anywhere, but we're already having discussions with Eurocall, and we are pushing them hard to say that, look, you can't keep undertaking valuation studies for one country a year in Africa. We need you to do more. We've also mooted some multi-country valuation studies that we're going to pilot with Eurocall, and then, of course, some of the process guidelines and other, methods, guidelines that we will develop, some of them would have country characteristics, but some also have regional characteristics. So, for us, it's not discouraging countries from doing that and going more of regional or going more country and ensuring that the 55 countries do. It's about pulling together every approach that helps overall to strengthen the evidence base for decision making.
Thank you, Justice. And I think that's the perfect segue to first acknowledge that we've got representatives from 3 member states. So we've got representatives from Malawi, Ethiopia, and Tanzania. And I just wanted to invite them to, give some thoughts about what we've been discussing. So if you want to comment on what we are discussing, it is the moment to do so. Gerard, please, yes. Yes, okay. Please introduce yourself and then your remarks. Thank you.
Thank you very much. My name is Afork, Director General for a research institute in Ethiopia called Armaur Hansen Research Institute, which reports to the Ministry of Health. I have to say I'm lucky to join this panel. I was not the one proposed to join originally, but later signed by my minister. As a leader of a research institute in Africa, which lived for over half a century, this discussion, this panel has many far-reaching implications, not only to my institute, but also to the health system in general, and also other systems which impact the health system delivery mechanisms in my country. So I'd like to thank the Deputy DG and the other speakers for highlighting those important points, and the respected panel, again, for touching how very essential prioritizing our resources and using evidence for decision making is. We need this kind of discussions now and again. In my part of the world, including my country, investing for evidence generation is not widely practiced. we are here talking about the importance of evidence. But first, you have to generate the evidence. So do we have that culture? We need to learn from the other parts of the world. That's where the SDG number 70, goal number 17 comes. When we partner, when we collaborate, we can learn whatever has been gathered and synthesized in Philippines. We can learn from that and adapt something from that and take that to Ethiopia and try to learn. So for me, evidence is important for the priorities. Our priorities lists are a lot. We have a very long list of priorities. But prioritizing by picking from the priorities need evidence. So that's what my respected panelists you have been mentioning. In Ethiopia, we have a new revised health policy after almost 30 years. That revised policy benefited from the few evidences generated over the years by higher education institutions and research institutions, and also development partners working in Ethiopia, addressing the various health challenges, health issues, and the assessments of programs and the results which came out from those. So we benefited from evidences generated by various mechanisms to revise the bigger health policy. And inputs again from studies are also being used in revising our proclamations in health, regulations in health, guidelines, directives. All those are helping us to look into the structure. One of the panelists mentioned about homegrown solutions. As a country, we are reforming many sectors, but our bigger plan, our bigger pillar for the plan is the reform approach to change in the future. All that needs evidence. So my colleagues, instead of taking too much of your time, I will stop here. But I would like to underline, we need to invest resources so that we can have evidences generated by the various systems we have. And we use those evidences to prioritize from the various lists we have, all of which sometimes are top priorities. Then you get into a big challenge of picking the first. Thank you very much.
Thank you. Priorities within priorities and the value of homegrown evidence. So now I open up for...
Rad is there.
He doesn't seem very keen.
No, he was going to...
Thank you very much for the opportunity. I think I'm just going to reflect on 2 points that the panelists have made. And the first one is really making sure that these principles are established in our countries in a cost-effective approach. Because obviously, in the African context, the opportunity cost of healthcare resources is very high. So it's really how do you make sure that the evidence-informed priority setting process is really set up, establishing a very cost-effective process. It's not seen as taking away dear resources, service delivery resources. That would be the first point. And then the second point is really the difficulty of implementation because of where most of us are at, where we're coming from. And Pete mentioned that point about the extent of fragmentation and how priority setting is really kind of a battleground because there are donors, different donors with their own priority packages, and then there's a government benefit design approach, but mostly there isn't coherence between this process. So I think the kind of principles and whole process side is not the most difficult part, but it's really how, after you've done that, how do you as it were, dismantle all these power processes and have one national process and make sure that the resources align to this process. I think that's the hardest part. So I just wanted to reflect on these two processes, 2 points. Thank you.
Thank you. Very good points. So we've got the point. Sure. We've got the point on the opportunity cost and how it is actually bigger in some of these settings, and the importance of actually having the same priority setting processes with external financing as with internal financing. Thank you very much, Gerard. Yes, now we've got our final final remarks from Tanzania.
Thank you to all the panelists for sharing very important insights with all of us. Again, from Tanzania, I think I'm not very far from my colleagues who just shared their insights as well. As they have said, I think one of the challenges that we're facing, especially maybe I would say where I'm coming from in most of the African countries, is how to generate that evidence. If you look at the amount of resources that we spend on research, you know, is still very, very, very low. But even in terms of institutional capacity, you know, for our research institutions, because if you want to generate evidence that is really, if you want to generate information that is data-driven, you really have to go into research, you know, so that you can get information that can really help you out. And I'll just share an example in Tanzania, what we did. We really had a problem of maternal mortality in the country. That was a big problem in the country to an extent that, you know, we had a lot of partners and donors coming in the country to support in that area. But as one of my brother here said, the coordination was really difficult. So everybody came with a different approach. We did not have a common approach, the government and partners, until when the government, we said, no, we need to dig down and see exactly what the issues are. What are the problems? And then after doing our homework, we came up with main 3 issues that we said, if we address these ones, probably we are more likely to reduce maternal mortality in this country. So one of them was the people themselves. You know, you cannot have any intervention in this sector if the people are not the center of the intervention, if the communities are not the center of the intervention. And again, the other thing was the skilled human resource, okay? And we had an issue of infrastructure. So we sat down with the Minister of Finance. We had health economics from the Minister of Finance. We sat down and we said, okay, fine. Let us develop a model that is going to help us, you know, to address the key barriers that we have identified. And let us really come up with a model that will help us to see which one do we start addressing and how do we scale it up, you know, where do we start, which part of the country? Because even the maternal mortality was not, you know, was not uniform in the entire country. So we came up with a model which actually guided us where to start, which intervention we start with, how much we are going to put in there, and how much we are going actually to reap out of it. So in a period of about 10 years, we were able to cut down maternal mortality from 556 deaths per 100,000 live births to 104 per 100 live births. But if you look into that, it's not like we had new funding from anywhere else, but it is the approach that we took. We were led and we were guided by evidence from the field. That's what actually helped us to come up with interventions that were cost efficient, okay? But also, they were very much embedded in the communities, in the system. And after seeing that, after, you know, getting those results, then we went back to the table with our partners. We told them, you know what? From now on, this is the direction. So then we realized in the course of doing that, that the problem was not even the finance. The problem was working in silos, inefficiencies in resource utilization. So we might talk of resources, et cetera, but really the systems, the structures, the way we do our business also has an impact in what we do. So the issue of efficiency is also very, very, very important, but also harmonization of our approaches, harmonization of and integration of our interventions is very, very important to make sure that, you know, we achieve very high, but using very little resources. Thank you.
Thank you very much for sharing that example. Now I open the floor for questions. Yes, please. Please identify yourself and then ask your question.
Thank you very much. My name is Patrick Nguku. I'm with Afinet in Nigeria. Very good discussions. Thank you. Very educative. So I'm trying to reconcile 2 issues. Resource allocation is a political sort of process from where we come from. Deputy DG knows very well about bottom-up economic transformation and renewed hope. Priority setting looks like a scientific, systematic approach. So how do we reconcile the two? Sometimes they pull towards different directions. Just from a layman's point of view, how do we reconcile these two? Thank you.
Thank you. We take a few questions and then we ask our panelists to comment. Yes, please.
My name is Antana. I'm from the International Institute for Primary Healthcare. One thing I want to understand is, in terms of setting priorities with evidence, countries, given the current realities where countries are constrained with a narrowed fiscal space and debt as well, the repayment plans and so forth, how can we support countries in terms of addressing the change in priorities, not only the setting, but these are now becoming dynamic. Now it's not static. That's one thing. The second one is about primary health care. We know primary health care is, you can deliver 19% of the interventions through primary health care. And what can Africa CDC do in terms of making primary health care investable? And, it's a priority among member states. And the third question is in terms of optimizing resources. We have got requests from member states and where we had to organize harmonization and alignment, where there is fragmentation at different levels, and we were sharing Ethiopia's experience. How can that can be scaled up to these lessons can be shared to other countries in Africa? Thank you.
Thank you. Question there? Yes, please.
Good day all. My name is Christopher Chukwu. I work with University of Oxford, and formerly I work with Nigeria Center for Disease Control. So it's not, I'm trying to bring up some issues, to suggest some things, or for us to think around some particular things. So basically, when you talk about research, especially evidence-based research, I'm really happy that we are talking around that area, because I remember when I was doing my master's, I was trying to get evidence to do a systematic review, because we are mandated to use primary studies. So doing RCTs in Africa is very, very important, so that whenever you want to also still do a systematic review, it will be very easy for you to gather substantial evidence to do that research. So also, I would like us to look at how to retain or how to advocate more, so that those healthcare workers, especially the qualified ones, to see how we can, speak to the government or how to advocate more. Because when you want to, perform all this research, you need qualified people. So sometime I was discussing with my friend, he says it's only in Africa that we don't need healthcare workers. So because a lot of people get trained and disappear. So we need to start looking at how to, hold them back, not holding them back by unethically, by making sure that they are being, being comfortable to do their work, and also support the research that we are planning to do. So thank you.
Thank you. So we've got a wide range of questions. Tessa, you want to take some of those and then we go that way, or?
I think they were due some speaking time.
Okay, yes. Well, Miraf, do you want to take some of the questions?
Okay. So maybe I'll start with an interesting question on how do we reconcile the political nature of priority setting and the scientific nature, right? Yes, priority setting is ultimately a political process, and our high-level decision makers or the politicians are the ones to ultimately make the decision. But and of course, historically, the decisions tend to be based on prior trends or, as you said, politically charged. But I don't think that our political leaders don't value evidence. If we, as a scientific community, can properly convey the message in a way that they can understand, and in a way that they can, incorporate it and carry forward in their decision making. I think the rationale behind considering evidence, being rigorous in incorporating those scientific principles, nobody argues about efficiency, nobody argues about equity, right? So, but the way we, as a scientific community, usually present it may not have served us well. So, as being positioned in a political institution, the AU, and having a mandate to engage high-level policy makers, including heads of state, but also ministers and so on, it's actually our comparative advantage to build the capacity of these high-level policy makers to be able to understand our point of view as a scientific community and carry forward and incorporate these principles into the decision-making. So if we do our job well as a scientific community, I think there's no argument that the political decision makers will increasingly move toward this, the desired approach to decision making. Yeah.
Thank you, Miraf. Pete, you want to answer some of the other questions?
Sure. So just on the burden of disease kind of change in priorities question, I think that's very much a capacity that all countries need to develop, planning for the NCD epidemic, planning for the next pandemic, all these planning for antimicrobial resistance. There are lots of long-term trends that countries need to be aware of and build the capacity to analyse internally as part of these priority setting systems. I guess I would flag that this is a good area perhaps for multi-country collaborations, because in general, lots of countries are facing similar trends, and it should be possible to share resources on that for efficiency. On the kind of PhD investability issue, primary healthcare is extremely cost-effective and very investable. I think we should be confident that as we strengthen priority setting, it should help governments see the value and see the importance in investing in primary healthcare. I guess one complexity to be aware of is that primary healthcare involves lots of interventions coming together on a kind of common platform, serving a community in lots of different ways. And the methods in some of this struggle with that. And so I think there's some work for academia to do on that. But broadly speaking, I think this field should strongly support primary healthcare. Thanks.
Thank you, Pete. Justice?
Yeah. The political and the systematic or scientific, they won't always align. But I think the divergence really is the speed. You know, when politicians ask questions, they wanted answers yesterday. They wanted answers yesterday, and it's important that we move with that speed. And I think for us at Africa CDC, this exercise is not simply an academic exercise, because the African Union is a political organization. It's important that we bring the policy, the political, and the scientific community, which is the point in what we are trying to do. We had the honor of hosting a former finance minister in our team for 9 months. 9 months he was with us in Addis, and he was part of the health economics program. You know, he undertook some of the country missions with us, and he said, Justice, if I knew what I know today about priority setting, when I was finance minister, I probably would have paid more attention to health. Anyway, he is back and he's finance minister now, so we only have to wait. We have to wait to see what happens. But
one of the 3 countries.
Yes. But the point is, we really need to speak, we need to understand the language of the politician. And I think the example you gave about the bottom-up approach, the real question is, even in the bottom-up approach, are there ways that we could implement interventions and be less wasteful? I believe if a politician understands that well, he would want to spend $1 and reach, you know, more people, right? Because he's a politician. So the way we explain this, the way we interact with them, it requires patience on our part. But I think with time, we will see some divergence. I mean, in terms of PHC, so that's the point. You know, when we talk about priority setting, there is evidence for different interventions. The most important thing is how do you pull the evidence together to let this evidence speak for itself, right? We often, as economists, are put in the, priority setting people are put in the corner to back one intervention. And that could be a challenge because you let the evidence speak for itself. At the moment, within the team, we are actually pulling together some work to determine what in the range of PHC and community health worker packages of interventions present the most value for money for countries to present. Yeah. Right? We can make that argument, but when we get to the politicians, we need to show them evidence. And I think this is one of the things that we need to do, to gather the evidence and let the evidence speak for itself. Let me just finish by saying that this same finance minister I talked about, he said he actually put money into the PES to put up the National Public Health Institute to fund it. And the only evidence that he got was when the then director of the NPHI came to him and said, if you actually put $1 in building the National Public Health Institute, you actually in economic terms will reap a certain, $7 or whatever dollars. He did not think about anything else but to dip his hands and pick a few millions of dollars and say, okay, let's go. So we are standing between not only the health community, but also the finance community. Because often when we speak to health, we talk about efficiency. And sometimes we talk about funding, additional funding, domestic funding. We usually speak with the wrong people. And when I like to talk about priority setting and not bring in the context of donor funding. Because for me, like Tanzania rightly says, sustainability is not your ability to ask for more, but actually your ability to do that from your own coffers. And that is what we should be focusing on. Not so much, what is coming from other people. There are questions to be raised. But all in all, it's important for us to look at sustainability in terms of what we can put in and how we spend that money in a way that we could actually achieve more with the little we have.
Thank you, Justice. So we're coming to the end of the panel. I'm just going to ask each of the panelists to reflect for 30 seconds what you want the audience to take away with them, or anything that you think you was food for thought. So Tessa, you want to get us started? Final remark?
Final remarks. I think it's not as easy as what we say it is, and it will always be political. I think we just need to just consistently work at it. It will take time, but I think it is putting together a culture of really, not just in priority setting, not just in selecting interventions, but in like how our Tanzanian colleague talked about it, in every place where we make a decision, it is about what do we know for sure, where we have confidence, and where do we have to make assumptions, and make it transparent and consult. I think as a process, HTA has set the standard, and we should just propagate it in every part where we think about making decisions. And that way, it will be easier for us to actually promote this process of making decisions. And maybe 5 years down the road, 10 years down the road, maybe this will be a standard already. And maybe in Africa, it will be faster. You should make it faster. We should.
It will be.
Thank you. Thank you, Tessa. Justice, final remarks?
Yeah. Things are changing in Africa. The context is changing. The policy, the political motivation, to spend better is changing. I would like everyone here to go with this, that things are changing for the better. Africa CDC is there to hold the hands of countries, and we've seen the demand, for countries around an Africa-led framework or a platform that helps them build sustainable capacity. This is what Africa CDC is doing. So we'd want, each of our partners to really rally around this framework because it is what countries are going to use. And we do hope that 5 years down the road, we will see better sustainability in terms of capacity, but also in terms of informing decisions that are made on the continent.
Thank you, Justice Miraf.
Yeah, I think I'll just echo what Justice has said. He has stolen my message.
Okay. Final remarks?
Yeah, thanks. I think it's been a really wonderful session. I think, I guess, a key takeaway for me is this is an area that works. It's really impactful, not only for improving lives, but also hearing a lot about how it's empowering. It can lead to sustainable use of domestic resources. It allows countries to work together and collaborate. And I'm really excited to watch what happens next in the Africa continent on this topic. Thank you.
Okay, so with that, please thank you all, my panelists. A round of applause. It's been a wonderful conversation. And we'll be watching this space to see the developments in Africa and beyond. With that, I want to invite Dr. Jenu to come and close the event before we go for drinks and conversations. So if you could please formally close the event, that would be great. Thank you, Dr. Tash.
Right. Please, can we give our panelists another round of applause? Yeah, I've repeatedly said that one of our biggest problems as public health, global health, or practicing physician is the fact that we do not get our framing right when it comes to unlocking resources. And when Patrick was talking about the Renew Hope agenda, it is not an African Union agenda. That's a member state agenda, and I think one of the unique, selling point or one of the unique advantages of Africa CDC is the fact that we are a specialized technical institution within an intergovernmental political organization. So meaning that whatever we have discussed here today, the framework we are trying to put together, we can actually leverage that political, the platform at the African Union to drive that agenda. We just need to run it through the appropriate policy organs. That's one. Number two, in terms of convening beyond one single sector, I think it's also one big advantage that we have as Africa CDC. And in the course of responding to the COVID-19 pandemic, we did that and we did very well. We were able to bring together the ministers of transport, the ministers of finance, the ministers of health, the ministers of national planning, to really sit around the table, and agree on how do we approach this issue of access to commodities, in the face of the challenging, response to the COVID-19 pandemic. So really, on behalf of the DG, I think this is something that is really close to his chest, and he will really look forward to advancing this agenda, leveraging the necessary policy organ within the African Union. So, colleagues, ladies and gentlemen, having said that, let us challenge ourselves to own and consistently apply evidence-informed priority setting principles when we go back to our respective destination. In the spirit of the new public health order, let us rally behind this member state-led, member state-owned agenda. So talking to the partners now, let's rally behind this member state-owned and member state-led process so that we build the necessary capacity that will allow our member state to be able to use this very important tool to unlock resources. Number three, let us serve as advocates of evidence-informed priority setting while we are trying as much as possible to increase health financing. Last but not the least, Africa CDC stand ready to support and back this agenda. I thank you.